Lindsey Smith welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. We're happy to continue our Year of the Zebra series on rare diseases today with Shanthi Hegde, a national advocate working to transform how rare bleeding disorders are understood, treated, and supported. Shanti is a rare disease patient herself living with 2 bleeding disorders and immune dysregulatory syndrome. That personal experience fuels her advocacy work, which spans mental health access, affordable drug pricing, and research equity for women of color with bleeding disorders. She also led the first U.S. Young Adult Bleeding Disorders Initiative and partnered with Sanofi to launch a Young Adult Summit, which created a platform for education and advocacy surrounding rare diseases. Shanti currently serves on the board of Hemophilia Federation of America and works as an Expanded Access Program Coordinator at Unifar, a global healthcare services provider. She's also pursuing a Master of Public Health degree at Brown University. Before we get started, and for those who may be unfamiliar, Elsevier's Year of the Zebra is a global initiative started back in 2023, dedicated to raising awareness and support for the rare disease community. Throughout the years, we continue to spotlight one zebra, a different rare disease each month. The goal is to shine a light on the patients living with these conditions and the worldwide efforts underway to develop therapies for them. And if you're wondering why we use the term zebra in medicine, it's become a symbol for rare diseases because unlike the more common horses, zebras represent the diagnosis clinicians don't see every day. Shanti, thanks so much for joining us today.
Thank you for having me. I'm just so happy to be here.
So to start us off, I'd love to learn more about your background and early life, kind of outside of your health journey. Can you tell us what shaped you before you entered the rare disease world?
Yeah, so I would say my early life passions and also some of my health experiences are quite honestly kind of intertwined. So as a kid, I was constantly sick with infections. I remember missing like 30 to 40 days of school some years. And I do remember sitting there being like, wow, I want to be a doctor someday to help kids like me who didn't always have super clear answers to everything that was really going on with them. And so science really just ended up becoming the way that I understood myself. And so I then transitioned to becoming an undergrad at Northeastern, and I really threw myself into research. I spent so many nights, countless nights in the basement of a building called Mugar on campus, pipetting samples when I could, running experiments, staying late into the evenings and sometimes the weekends when I really had the energy and I was in good health. And I really fell in love with immunology. I worked in discovery immunology as a co-op at Merck through the Northeastern Co-op program, and also tough cell biology at Brigham and Women's Hospital and Dr. Nora Barrett's lab. And these experiences really just gave me space to experiment, to really think creatively, to really understand these biological systems in a deeper way and more creative way as well. But at the same time, I really began to develop a appreciation for the bigger picture. I started off my career at Northeastern taking a class called History of Technology, and it really influenced how I understood science and how we talk about technology. Like I remember writing a paper on how automobility shapes system of power and race and inequality and things we really never touched upon in my K-12 education growing up in North Georgia. So it really made me realize that I was so passionate about multidisciplinary ways of thinking. And so I transitioned actually to studying the history of pain and pain perception. It really ended up being this research project that culminated throughout my undergraduate career. And I spent a summer studying at the University College of London during this time, and I conducted research with a UCL-based group called Global Threads. And I was really delving deep into the archives in Manchester. I was examining historical shipment logs. And around the same time, I was also coming to terms with my own health more deeply. And I realized that so much of my personal experiences weren't really necessarily separate from my academic interests, and they were the reason why I cared so much. So eventually I actually pivoted to psychology because it really felt like that perfect bridge between that like biology experience that I was getting, that humanities experiences that I really loved, and also loving the clinical aspects of it all. Like I spent a good chunk of my senior year examining the DSM-5 through clinical psychology coursework, and then also studying how like compounds interact with biological pathways in a course I took called Drugs and Behaviors. And then I had the opportunity to join a psychological humanities research group at Northeastern, where I was able to present some of my research at the American Psychology Association's Division 32, where I really delved deep into that. History is persistent throughout. It doesn't just stop in history. It's still permeated through present day. So I presented on Derrida's concept of hauntology and Fukuyama's The End of History and Last Man, which was a really very interesting topic to dive into. But at the same time, also on the side was doing a lot of human subjects research, really looking at visual perception under low light conditions. I was working in the Kwan lab with Dr. Mi-Young Kwan on campus, who also was my seminar professor for sensation and perception. And so I say all this because my path is just not linear at all. I started in immunology. I did history research. I am now in psychology. Like, you're probably thinking, what is she doing? And so that is actually something I'm really proud of. I never really limited myself, especially in undergrad, to one way of thinking. And I credit my mentors so early on for instilling that curiosity. And that curiosity and exploration are strengths. They're not weaknesses. And so pretty much all that to say, I ended up in public health now because I saw that as a bridge for combining psychology, biology, and the humanities together. And I thought that was the perfect way to combine all of my favorite things. And I realized that I started off by saying I wanted to be a physician when that was my dream since I was little. And for a long time, I believed that becoming a physician was the only way to help people like me. But over time, I really realized that I wanted to understand why people like me struggle to access care in the first place, which is why I transitioned to public health and now have the extreme joy of working in expanded access programs. So that realization really expanded my perspective, led me to public health, led me to ask bigger questions about health inequities, how we can design, thoughtful, culturally competent interventions. And access is something that I'm just so passionate about and dedicate my work to helping patients, especially those with rare diseases, getting access to life-saving therapies.
Wow, what an incredible story and really helpful context. I think it kind of sets the stage for understanding your path forward and where you are today. Can you take us back to your personal journey with bleeding disorders, including the diagnostic process? As many of our listeners know from Elsevier's Year of the Zebra initiative, getting a diagnosis for a rare condition can often be lengthy and very frustrating. Can you talk us through your experience?
Yeah, of course. And yeah, as you mentioned, my experience is very lengthy. So I'll kind of start off by saying I live with a few rare diseases. I have 2 rare bleeding disorders. One of my bleeding disorders is actually ultra rare. And then I live with a rare immune dysregulatory syndrome as well. And I really, to start off with the bleeding disorders aspect, I struggled with bleeding my entire life. As I mentioned, grew up in North Georgia. I was constantly bruising. I was honestly bleeding from everywhere and dealing with really severe heavy menstrual bleeding from a very young age. And, a bleeding disorder was never on my radar because I didn't even know that really existed. And in my mind, I learned about hemophilia in middle school, and that was something the royal family had. And how could I possibly ever have something like that, right? And so the irony of all of this is I was bleeding so much in high school, and I was also taking a class at the time called phlebotomy. And it began affecting my daily life in very visible ways. And I remember speaking to the teacher who really wouldn't let us go to the bathroom that often, that I needed to go to the bathroom every 20 minutes because of how heavily I was bleeding. And so she kind of looked at me like I was insane. And she was like, you might want to get that checked out. And I remember telling her, I have, and no one can figure out why. And so I missed a lot of high school. I missed a lot of middle school often because of it. And while sparing the gory details, I would sit in my bathtub for hours, just literally continuously bleeding. Like there would be a pool, quite a big pool of blood beneath me. And it really just got to the point where I couldn't exercise properly. I remember trying to do a spin class with the YMCA to raise money for kids to go to camp. And I couldn't ride that bicycle at all. It was very painful. My knees were constantly hurting. I couldn't sleep on my left side because my muscles were so painful. I couldn't tolerate anyone touching my arm when, like, the arm that I received vaccines on. To the point where I remember my mom once lightly tapped that arm and I was in such excruciating pain. She was very confused and she brought it up at nearly pretty much every pediatrician appointment. But still, no one really could figure out why. I went through physical therapy because of the bleeding. I went through so many things because of the bleeding. I was anemic. I would bleed for like 4 to 6 months straight. And eventually the only explanation that the North Georgia medical system really could offer me at that point was, let's see if you have endometriosis. And so at 18, I underwent a laparoscopy, the laparoscopic procedure for endometriosis. And that January that I got the procedure the end of December, and that January which was my senior year of high school, to pretty much the entirety of my freshman year of college, I bled continuously. I was pretty much exhausted. I was very exhausted. I was really weak. And by May of the end of my freshman year, I remember I was moving out of my freshman dorm and I was like, I need to go to the hospital. I'm passing out. And so I went to Northeastern, which is in Boston, and I'm very, very fortunate to have had to be around such a wonderful set of hospitals. And so when I went to Brigham and Women's Hospital, the OB-GYN took one look at my history and said, have you ever heard of a bleeding disorder? And I honestly remember feeling confused. On the ride home, I searched up this like long, very convoluted name she had given me. And that was when I had learned I had one. She tested my factor VIII levels. She tested a bunch of different factor levels and they came back low. And so my case was actually like pretty complicated. You would think it ends here. You got the diagnosis. Done. No. So during my first medication challenge, for those who don't know what desmopressin is, it's kind of the first line of treatment you get for the bleeding disorder I was diagnosed with. And especially with insurance, this was the first therapy that my insurance said, you got to take. This is the first one we'll approve. And this is an infusion over a set of hours. And I anaphylaxed to this medication. I had a severe allergic reaction. I had to be EpiPenned twice. And so with that no longer being a treatment option, I was placed on something called antifibrinolytics, which are pills. And one is called Amicar and the other one is tranexamic acid. And that actually caused really severe gastrointestinal symptoms for me. And I ended up GI bleeding. And so that now is not an option. So by my sophomore year of college, I needed a colonoscopy to figure out why I was GI bleeding so much. At the same time, I'm now experiencing immune dysregulation symptoms. I'm having high fevers reaching to 102 degrees. I'm having salmon-colored rash. I'm having severe joint pain. Night sweats, swollen lymph nodes. Like, I can't even get out of bed. And so I remember being tested for everything imaginable. Like, I went to CT scans. I was under MRIs, multiple MRIs, PET scans. Like every diagnostic test anyone can think of, I had. And so I was in the emergency room pretty much every few weeks. And through all of this, I was still bleeding. And so around this time, I was like, there has to be something wrong. Like there has to be something more wrong with my bleeding. Like we need to figure this out. Why am I bleeding? There's no other option for me. I find that hard to believe. And so this to me was incredibly difficult because I had always been raised to believe that doctors were always right. Questioning them meant that like, that's just wrong. That's taboo. It just felt so uncomfortable. It's so unnatural. But I remember the day I got my colonoscopy, I received my first dose of factor ever. And that moment changed my life. And that moment I said, this changed my life. Why do I not get this more often? And I continued to bleed for about a year after that, for months. I asked my doctor, my hematologist at the time, I said, what if we increase my treatment because my quality of life is still so poor? And I finally said, I need you to test me for another bleeding disorder if you don't think there is anything else going on with me. So I really kept pushing and I kept asking questions and I was pushing for answers. And it came to the point in 2024 where I was told by that previous hematologist that after I had pushed and asked questions for so long that, there's something wrong with you. You don't get what I'm saying. This is not because of your bleeding disorder. This is something else. She said that I lacked retention and she was surprised that I was even a pre-med student and that I just had anxiety and depression. And so she really dismissed my symptoms. And she also told me that doing further testing for another bleeding disorder would be useless because my previous provider was certain that it would come back negative. And her nurse said that my bleeding was nothing. She had seen worse and suggested that I just simply get an IUD. And on top of that, at multiple appointments, I was told that my bruises were just because I'm brown, because that's just the color of my skin. That's just melanin. That's just hyperpigmentation. And I was devastated. Spring of 2024. I was like, wow, I'm suffering so much, but I'm just being told that this is nothing. And so as soon as my previous provider told me that she was surprised that I was pre-med, at the time I was pre-med, I was like, no, I'm not taking this. I don't deserve this. So I picked up the phone and called every other hospital in the Boston area searching for another provider. And eventually I ended up finding the soonest appointment was that May of 2024. And I found an oncologist who agreed to see me. And I was really skeptical because I should be seen at a hemophilia treatment center, right? That's where all the benign hematologists are. That's where all the people who really know about bleeding disorders are. I should be seen at one of those hospitals. I was put on the wait list at all of those hospitals because they said, you're not severe. You're not severe hemophilia. We have a wait list. We can't see you. You're not severe enough. Putting you at the end. So this was pretty much my only option. So I went into this first appointment thinking, wow, I'm going to have to sit here and apologize that they can't see my bruising again because I'm brown. And I came in saying, look, I have bruises, but I'm really sorry that you can't see them because I'm brown. I have darker skin tones. And I remember this so vividly because this is now my favorite. This new provider that I was seeing in 2024 is now my favorite provider. He told me that I didn't need to apologize, that he could see them perfectly well. And I had tears in my eyes. Like that was the first time I had been heard. And so from then on, I realized, and so did my providers realize that I pretty much had been underdiagnosed. So I started receiving weekly factor infusions. I got a port, which transformed my quality of life. That doctor was curious enough to do testing on me, further testing, revealed that I have a second bleeding disorder, which is an ultra rare bleeding disorder. And so having one bleeding disorder is already kind of uncommon, but having two is extremely rare. And no one was expecting that because it's rare. Why would you have it, right? But no, I'm surprisingly, I have it. And so all this to say, I was told many times by many providers that these disorders are not common in Indians. And I'm of South Asian Indian descent. But I challenge that and say, how would anyone know if people like me aren't tested? Genetic diseases really don't discriminate based on race, but access to diagnosis and care really often does. And I say women and girls, especially women of color, just face enormous barriers to just being heard and believed. They're really often dismissed, like my own story. So when I look back at that whole diagnosis journey, which I really could go even into the nitty-gritty details of it, but this is kind of the overview. I really used to feel angry. Especially during my sophomore year of college, I had dropped out of pretty much all of my classes. I didn't think I was going to graduate undergrad, but I really no longer am that angry because I see my health as something that gave me perspective. It really taught me resilience. It taught me how to advocate for myself. I was put in the deep end at such a young age. I had to navigate all of this alone. I didn't have my parents. I was 16 hours away from my parents. My parents are in Georgia. That's a 16-hour car ride to Boston. And so it really gave me purpose, and it really gave me a purpose to continue advocating.
Absolutely. And thank you so much for sharing your personal story with us. That was incredible to hear. You go through that entire journey to, find a provider that listens to you, get to that diagnosis, and kind of given everything that you went through to get those answers, how do these conditions impact your life today?
it's still a struggle, I will say. And really, to give you a glimpse into what living with a rare disease looks like, I spent pretty much my entire December into January on the phone fighting with my insurance to get my medication approved. Each vial costs around $10,000 with administration. It's like an itty bitty tiny vial. But without it, I'm at risk for bleeds. And so during that time, I was literally on the phone begging for nursing access, right? I have a port. I was attempting to stick a needle in my arm. I was not able to get any blood return. I was really struggling to find nursing access. I was really lucky that I found out about Hemophilia of Georgia during December when I was at home. And I do have to absolutely say, like, they pretty much saved me during that time, because they helped me at a time where I thought I would have to just go to the ER every week and have to shell out this entire, like, all this money to be at the ER. And Hemophilia of Georgia receives federal funding to help patients like me. And having learned that during that time was just, they saved my life. And so, and to put that into perspective, if I miss a dose in November, I missed one dose and I developed a thigh bleed. And when I missed a dose in December, I was in the emergency room the day after Christmas. So living with rare diseases just really means constantly having to consider factors that most people don't really think of, like where I live. When I go back home, I have to go, like when I go back home to Georgia to visit my parents, to see my parents, I have to go through such an ordeal with specialty pharmacy, with insurance. It's also about, like, how close am I to a hospital, establishing providers, whether I will have access to treatment, period. Even physical activity, for example, like I can't really, like, still have trouble going to spin classes, for instance. I love to travel, but I remember when I studied abroad and took classes at UCL, I carried a cooler full of medication with me and struggled to find providers who could administer my infusions. And this was like over a 2-month span. So it was definitely really challenging. I ended up with a huge bleed in my left calf during this time. I could barely, like, walk. I was pretty much limping everywhere when I was studying abroad. And so this is like summer 2024. So this is like before I really learned how to self-infuse or how to attempt to self-infuse. And that's another thing is I talk about my phlebotomy class experience in high school. I never thought that this would be applicable to my life at all. I never thought I would have to stick a needle in myself or even attempting to even stick my own port. And then on top of that, having that immune dysregulatory condition, it really severely impacted my energy levels. It really made it difficult to attend classes. I was talking about how I dropped out of pretty much every class my sophomore year. And to my shock, like I still graduated. I look back and I'm like, I'm so proud of myself because I graduated college. I graduated college with flying colors. I graduated college with summa cum laude. So it took a lot of perseverance. It took a lot of, like, just having to just keep going because I was in bed. I had 102-degree fevers. I had night sweats. I was bleeding. It's also the fact that you're deciding between tuition and taking life-saving medications because at a point in my undergrad career, I got a bill for $10,000 and I was like, how am I supposed to pay this when I'm also having to pay tuition? And so really, despite these challenges, like, I had to really fast was put in the deep end and had to learn how to push through. And I don't recommend it because it had such an impact on me. I was struggling pretty much all 4 years of college and really had to work with my professors who were kind and willing to, grant me extensions that were semester long. Like if I took a final 6 months later than all the other students did because I was so sick and in the hospital. And so despite these challenges, like, these experiences really just taught me how much advocacy and equipping myself with knowledge is important.
I appreciate you pulling back the curtain for us and showing us what a day in the life really looks like. I had imagined that these experiences that you had directly influenced your next steps. Can you talk a little bit about your current work around advocacy?
Yeah. So I would say, like, I guess I first started getting engaged in advocacy shortly after I was diagnosed. It was an incredibly isolating time, especially during that summer between my freshman and sophomore years of college. I was really fortunate to have wonderful friends who stood by me and really learned alongside me in many ways when I was navigating something entirely new on my own. I am first in my family to experience many things. Like I'm the first in my family to attend a university like Northeastern, even the first to receive a diagnosis like this, because my family comes from a very small village where in India, where access to like specialized medical care, even let alone medical care, let alone testing for a bleeding disorder, just is just not something that exists. And so when I was diagnosed, I really didn't know a single person with a bleeding disorder. And I just desperately wanted to find that community who really understood what I was going through. So I joined the National Bleeding Disorders Foundation, and through their Youth Leadership Institute, I was able to find other young adults like me who had bleeding disorders and were struggling, and really learn about their experiences and share these experiences, which I'm so grateful for. And through that program, it was just so meaningful to connect with people who understood my experience. But then when I returned to Northeastern, I realized that sense of community was still missing on campus. And so really inspired by that youth leadership experience, I worked with some of my closest friends on campus, and I started my own chapter focused on bleeding disorders awareness and advocacy. And being in public health, I kind of know that global change really starts local, and really educating your local community. So after, starting this organization locally, I was a teaching assistant for genetics. And through the organization that I started, I spent time giving guest lectures to genetics classes, which were about 220 students, many of whom were pre-med and really didn't really know anything about bleeding disorders. And I gave them a glimpse to the reality of living with just rare genetic conditions in general. And some of my friends now who I started the organization with have gone to medical school, where I hear from them that they're learning about bleeding disorders now in patient care, which is always so amazing. And having the opportunity to now plan conferences, be a board member, and be part of these really important conversations, be also both on the medical side, be able to sit in on the National Bleeding Disorder Foundation's Medical Science Advisory Council meetings, and learn about gene therapy, and also really go into the advocacy world and learn more about women with bleeding disorders and be part of the conversations that the community members face is just made me realize the power of advocacy and really building that community.
Such important work. And in addition to what you just mentioned, you've also served as a program coordinator for the Bleeding Disorders, Substance Use, and Mental Health Access Coalition, and volunteer for the California Mental Health and Rehabilitation Center. So I want to come back to the mental health aspect for the rare disease communities. What do you want our listeners to understand about that?
Yeah, so I was a program coordinator and still kind of help out in any way I can in the mental health aspect of the community for the Bleeding Disorder, Substance Use, and Mental Health Access Coalition, as you mentioned. Especially for bleeding disorders, they're a very overlooked challenge because NSAIDs act as blood thinners. Patients with bleeding disorders typically cannot really use them safely for pain management, like Advil. Can't really take that because it is a blood thinner. So this means that when patients really experience those joint bleeds, which can be really, really painful, the primary option and pretty much the only option has been opioids. So over time, this has really contributed to this very unique and complex substance use and mental health crisis within our community, particularly among young patients with severe hemophilia or bleeding disorders or other bleeding disorders who are exposed to opioids really early in life as part of their medically necessary care. And at the same time, when bleeding disorders patients seek treatment for mental health or substance use, they are frequently denied access to inpatient or outpatient facilities. I would regularly call these facilities and I would say, we have patients in North Carolina or California at the local hospital that need access. And they would say, well, we have IV exclusion criteria in place and we cannot take them because of medical complexity. We don't really know how to navigate that. And as well as many facilities really didn't have the training or protocols in place to care for patients with bleeding disorders, which really creates that dangerous gap. And so BD Sumac was born out of the need to ensure that bleeding disorder patients have equitable access to mental health and substance use treatment, and that medical complexity shouldn't really be used as a reason to deny care. And so many of the coalition's wins came out of 2024 with that clarification in Section 504, which really helped reinforce that denying care based on medical complexity, specifically for hemophilia, can constitute disability discrimination. So this was really a major step forward in protecting, like through policy work and protecting access for bleeding disorders patients. But yet there's still a lot, like local regulations, and there's just still a lot because that language, while clarified, still there's a lot of work that needed to be done. And so my project with BD Sumac was working directly with healthcare providers like social workers and investigators and nurses at hemophilia treatment centers across 5 states to really help identify and build relationships with local mental health and substance use treatment facilities. So like I would be calling 200, 300 facilities in each state to identify those relationships. And so we really helped connect hospitals with facilities that were willing to receive that education on bleeding disorders to then safely care for these patients in that residential outpatient or inpatient setting. And the goal was to ensure that the providers had then trusted referral networks that patients could go to and not get turned away. And so this was so meaningful to me, given my background in psychology. And this work actually was accepted as an abstract for a presentation at the World Federation of Hemophilia Congress in April in Kuala Lumpur, Malaysia, which is amazing. I'm so thrilled about it, but I'm really excited that more people are recognizing this, and it really just deepened my passion for improving access to care, especially in mental health for rare disease patients, but then also access is something I'm really passionate about. So I was incredibly fortunate to step into an access role and expanded access program coordination at Unifar.
It's really interesting to hear, your personal life kind of intersect with your professional life. You advocated for yourself for so long. Now you're advocating for so many others, which is such important and meaningful work. I want to zoom out a little bit. When you look further ahead, like 5 to 10 years into the future, what changes would signal real progress in health equity for rare disease patients?
So I would say really like being in public health has opened my eyes to the reality of rare diseases in all aspects of research and policy conversations. Like in epidemiology, for instance, like screening and population level research really focuses on high prevalence conditions because like statistical measures like you learn in epidemiology, like positive predictive value, really depend on prevalence. So when diseases are rare, they can be harder to detect and study and prioritize in large scale public health work. And so especially because, of people thinking about false positive rates. However, even if I've mentioned this before when I, talk to a lot of public health folks, is even if each rare disease affects only a small number of people, there are so many rare diseases. There's like 7,000 rare diseases. So pretty much like 1 in 10 Americans, I would say, has a rare disease. So that's still millions of people. So in reality, rare disease is a public health crisis, and it's such an invisible public health crisis. So I really learned to appreciate the prioritization of burden through the social determinants of health. So like really quality of life inequities, like diagnosis delays and more. I think the biggest thing, especially in terms of equity right now, is improving recognition and care for women and girls. Historically, bleeding disorders has been viewed primarily as a condition affecting men, especially hemophilia. But we now know that women and girls are significantly underdiagnosed, and they often experience delayed care despite having substantial bleeding symptoms, like my own story. And so I think that's the power of advocacy, right? And so taking this to legislators, doing that advocacy work, really closing those equity gaps. Much of the progress we have seen comes from patients and advocates showing up on the Hill or locally in states like Massachusetts and Rhode Island to share our lived experiences. And so while there has been, ongoing issues, especially because so many patients, rare disease patients, are on Medicaid and Medicare coverage, and that is something that is slowly going away, unfortunately, given our current political environment. Still showing up is something that's so important. It's the only thing that could really help some of the inequity gaps right now. For instance, something that I always like to share to promote hope currently is one of the biggest bleeding disorders pushes right now and legislative asks is all copays count. And so in several states, including the advocacy efforts of, I want to say, the amazing Stephanie Lapidow from New Jersey, who's the executive director of New Jersey's bleeding disorders chapter, and the amazing individuals in the New Jersey bleeding disorders chapter and the rare disease community have successfully passed copay accumulator bans in New Jersey, actually February 2nd. In Massachusetts, there's currently a legislative session with active advocacy efforts to implement similar protections, working through the New England Bleeding Disorders Advocacy Coalition. So there's a lot of momentum right now, and especially with, newborn screening specifically for women and girls, with that being asked through Hemophilia Federation of America. Many patients, especially women and people of color, experience those significant diagnostic delays. So when we continue to share those patient stories, when we continue to engage with our policymakers, it really ensures that we have our voices heard, and they're realizing that there are inequities that are constantly existing, and that we remain visible in these policy conversations is the only way that we're going to continue to close those gaps.
Exactly. A lot of momentum happening in the space, but still at the same time, a lot more work to be done. For our listeners who want to support that kind of future and learn more about your work and get involved, where can they go?
They can absolutely reach out to me. My personal email is just my last name, Hegde, HEGDE.SHAN at northeastern.edu. I use it as my personal email now. I would also be thrilled to connect with anyone on LinkedIn. I'm always happy to chat, not just about my rare disease journey, but about anything else related to my work and my passions.
Awesome. And we'll be sure to include those handles and information in the show notes. Before we wrap up today's episode, we have a lot of students and early career health professionals listening in. I know you've talked about some of your providers earlier on, some good, some maybe that dismissed some of your conditions, symptoms along the way. I wanted to ask you, what's your advice to them about meeting the challenges of this moment and building a career in medicine?
Yeah, so I often really return to the image of the disease iceberg. It's like a concept that we learn in public health where disease burden is underestimated. And so what clinicians see above the surface is most visible. So those are like the severe cases. You get people with spontaneous hemorrhaging of the brain. You get like very severe hospitalizations. Your factor levels are 0. And these patients are very, very much easier to identify. They're easier to diagnose. They're easier to really receive those timely access to care. But beneath the surface really lies a much very larger, very less visible population, like individuals with mild hemophilia, von Willebrand's disease, whose symptoms are subtler, like those lab values may appear borderline. But those are the folks who are frequently minimized. They're dismissed. They're not necessarily heard. So I always say numbers do not always correlate with phenotype. And so I guess my biggest message first for current clinicians is that I would say believe your patients. Patients really know what they're going through. They know when something's wrong with their body. They live with their symptoms every day, and sometimes their experiences may not fit neatly into what's written in textbooks or even criteria. For example, all of my immune dysregulatory symptoms very much fit under Still's disease. Yet I am missing one laboratory value that puts me at the perfect Still's disease patient. Yet I'm now atypical Still's disease, right? And so I'm on an IL-1 beta biologic plus many other steroids and methotrexate and Plaquenil. But that combination has really changed my life. But it wouldn't have happened if a physician wasn't willing to look beyond the textbook. And so I think for me, even with symptoms that didn't fit traditional patterns, I had physicians that continued to ask the questions. They listened to my concerns. They consulted with other physicians, and they treated me as a partner in care. And so rare disease patients really often spend so many years searching for answers. And through that process, we really become familiar with our own bodies. We're more intelligent than people think we are. And so when a patient raises a concern, it's usually because they've lived that experience repeatedly. And so I say that, really believe your patients when they come to you and say there's something wrong, because almost 9 out of the 10 times there is actually something wrong. And I guess for medical professionals that are going into the field, early career, even folks that are in high school or college, I would say go into medicine for the right reasons. Go into it because you're genuinely willing to listen, because you care about helping patients navigate uncertainty. I thought for the longest time I wanted to be a physician, but that really changed when I saw the healthcare system. And I thought, I really want to focus on making sure that I see to it the access of care issues and the foundations of healthcare rather than, doing more of that rigorous science work and putting the puzzle pieces together to find out what the patient has and really help that patient navigate that process. I would rather work on the nitty-gritty access issues in the first place. I really wanted, that was a passion of mine, that still is. And so I really would encourage folks to do that soul searching and to not be afraid to deviate from the norm. And as someone in public health, I would also strongly encourage students to take humanities courses along with their science training. Unfortunately, there is a perception that arts and humanities are just less valuable than, let's say, organic chemistry and physics. But in reality, they are essential to really becoming that thoughtful physician or that thoughtful scientist, because like history or psychology, for instance, really helps you understand how patients experience those illnesses, how cultural competency happens, how social determinants really influence our healthcare systems. In fact, one of the Healthy People 2030 goals is to improve health literacy. And a central part of that is strengthening communication between patients and providers. So being able to explain complex medical information clearly and have that empathy to listen, especially for patients who don't speak English as their first language or are from immigrant populations. And then finally, I want to say for the students who are questioning themselves on whether they should go into science or medicine, I want those of you to know that self-doubt is not a sign that you don't belong. It's often a sign that you care about what you're doing, because questioning yourself is really normal, part of that normal growth. But I also want to acknowledge I'm very early in my career. So I'm not someone that may have so much experience around this. I'm still learning myself. But from what I've come to understand is that our sense of confidence is something that really is developing over time through experience. And there is really no such thing as too many mistakes. When I first embarked on this journey, actually, when I was in high school, I remember being told that you could make too many mistakes. But looking back at it, that person was absolutely wrong. People who make mistakes are human, but people who are willing to do those mistakes again and again for the sake of learning are passionate. And science is a walk. It's not a sprint. It's not a run. It's not a competition. It's not whether you pick things up the fastest or whether you finish getting to the line the quickest. From the patient perspective, that passion really matters the most to me. And we as patients honestly need clinicians who are willing to stay engaged and who are not afraid to learn together and who approach their work with humility.
So many good pieces of advice there. I particularly liked when you said that providers should be partners in care. So we'll take that along the way. But before we wrap up today's episode, is there anything that we didn't cover that you feel is important to add?
I guess not anything that we didn't cover. I mean, I just wanted to add that the genetics lecture I gave, I utilized the Osmosis clotting cascade to explain the intrinsic and extrinsic pathway to students. So I just wanted to say thank you so much for highlighting some of the ultra rare bleeding disorders. Like Glanzmann thrombocythemia and Bernard-Soulier are platelet disorders that are rarely discussed outside of specialized benign hematology settings. So having that representation is just really incredibly meaningful for patients with ultra rare bleeding disorders and platelet disorders.
Thank you so much for the kind words. I think that was added on as part of our Year of the Zebra series, which started back in 2023. We've continued. We hope to continue for many more years because we know there is so many more zebra conditions to cover along the way. Thank you so much for being with us today.
Thank you so much for having me.
And that brings us to the end of this episode of Raise the Line. My sincere thank you to Shanthi Hegde for sharing her story, her expertise, and her remarkable commitment to improving the lives of people with rare bleeding disorders. If you enjoyed this conversation, we invite you to explore more episodes in our Year of the Zebra series, where we continue to highlight the voices, challenges, and innovations shaping the rare disease community. You can find us on your favorite podcast platform, and we'd love you to subscribe and share the show to help us keep raising the line and strengthening our healthcare system. I'm Lindsey Smith. Thanks for checking out today's show. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisetheline podcast.